Low blood sugar can happen with Wegovy, which contains Semaglutide, or Zepbound, which contains Tirzepatide. However, the injection is rarely the whole story. The greatest danger usually appears when appetite drops, while insulin or certain diabetes pills stay unchanged. Most people without diabetes face a much lower risk. The real question is not which brand you use, but what else is lowering glucose beside it. These drugs help the pancreas release insulin mainly when blood sugar is elevated. As glucose moves toward normal, that insulin signal becomes weaker. This built-in brake makes a severe low less likely when either drug is used alone. It does not protect you from another medicine that keeps pushing insulin into the bloodstream. This built-in brake creates a common misunderstanding. Wegovy and Zepbound do not need to act like insulin to be linked with low blood sugar. They can reduce food intake without directly forcing blood sugar down. Risk appears when smaller meals meet another medicine that keeps lowering glucose. That combined risk matters when glucose falls below 70 milligrams per deciliter, the usual alert level. That reading should trigger treatment. A level below 54 is more serious because the brain may receive too little glucose. Shaking, sweating, hunger, dizziness, blurred vision, confusion, or a racing heart can follow. If you use insulin, this matters most. Long-acting insulin can keep working after several days of reduced eating. Mealtime insulin can overshoot a plate that is half its previous size. The insulin dose stays the same, while the smaller meal provides less glucose. These drugs can slow digestion, creating another timing problem with mealtime insulin. Food may reach the bloodstream later, while injected insulin starts working sooner. This mismatch can cause an early low, a later rise, or both. Insulin is not the only partner that raises risk. Sulfonylureas are diabetes pills that make the pancreas release insulin for hours. Common examples include glipizide, glimepiride, and gliburide. They can keep working when breakfast is skipped or nausea limits dinner. Metformin works differently and rarely causes low blood sugar by itself. One Zepbound trial involved adults with type 2 diabetes. Glucose below 54 occurred in 4.2%, compared with 1.3% with placebo, an inactive injection. That means the low occurred more than 3 times as often with Zepbound in that study. The contrast became sharper among people taking a sulfonylurea. The rate was 10.3% with that pill and 2.1% without it. In practical terms, the rate was about 5 times as high among people taking that pill. A Wegovy trial found glucose below 54 in 6.2%, compared with 2.5% with placebo. That means the low occurred more than twice as often with Wegovy in that study. One severe episode required another person's help. That severe case shows the risk can become an emergency. The trials enrolled different people and used different designs, so the results cannot support a fair brand comparison. More importantly, feeling shaky does not prove your blood sugar is low. Nausea, dehydration, low blood pressure, anxiety, and eating too little can feel remarkably similar. A normal reading makes low blood sugar less likely. Someone may feel terrible with a glucose reading of 105. Treating symptoms with candy despite a normal reading adds calories without fixing the cause. Meanwhile, repeated lows can weaken warning symptoms, even in someone who once felt every episode. A dangerously low reading of 52 can then appear with little sweating or shaking. Symptoms can therefore mislead in both directions. A rapid fall may create symptoms before the number becomes truly low. Someone accustomed to glucose near 250 may feel shaky at 110, even though 110 is not low. The body reacts to the speed of the drop, not only the final number. The symptoms are real, but extra sugar is not the automatic answer. Symptoms may show what is happening, while risk factors explain why. A dose increase can reduce appetite, vomiting may leave little food available, and a long walk uses more glucose. Alcohol reduces the liver's ability to release stored glucose overnight. Together, these pressures can turn a stable routine into a 3 a.m. low. For adults over 65, there is less room for error. Kidney disease can allow insulin or certain pills to remain active longer. Memory problems can cause missed meals or extra doses. A previous severe low is another warning, because the same pattern often returns unless the treatment plan changes. Someone taking Wegovy alone for obesity faces a different level of risk from someone taking Zepbound with insulin and glimepiride. The first person may feel weak from dehydration while glucose remains normal. The second may have a true medicine-related low. Same symptom, different danger. To judge what caused the episode, start with 3 facts: measured glucose, active glucose-lowering medicines, and recent changes. Check dose increases, insulin doses, pill names, meal size, vomiting, alcohol, and unusual exercise. That pattern identifies the real risk better than the brand name. Timing then separates likely causes. A low soon after mealtime, insulin points toward a food and dose mismatch. A low before breakfast may suggest overnight insulin or a long-acting diabetes pill. A normal reading during dizziness makes dehydration, low blood pressure, or another cause more likely. When timing clues do not fit, repeated lows without insulin or a sulfonylurea may have another cause. That pattern needs medical evaluation instead of blaming the injection. When insulin or a sulfonylurea contributes to lows, closer glucose monitoring is needed during Wegovy or Zepbound dose changes. A continuous glucose monitor, a wearable sensor, can reveal overnight drops and patterns. Pressure on the sensor during sleep can create a false low. A fingerstick meter, which checks a drop of blood, can confirm an unexpected alarm. Prevention should begin before the first serious event. When appetite and glucose are already falling, a clinician may reduce insulin or a sulfonylurea. The correct adjustment depends on current readings, meal size, kidney function, and previous lows. Copying another person's dose reduction can create high glucose instead. One isolated reading should not make you stop every diabetes medicine on your own. Record the glucose value, time, food, activity, symptoms, and doses taken. Several entries can reveal whether the problem is mealtime insulin, overnight insulin, a pill, or an illness that prevented normal eating. When a reading confirms glucose below 70, take 15 to 20 grams of quick-acting sugar if you can swallow safely. That amount raises glucose without turning treatment into a full meal. Glucose tablets or regular juice work faster than chocolate because fat slows absorption. Recheck after 15 minutes and repeat the treatment if the reading remains low. Confusion, seizure, unconsciousness, or inability to swallow is an emergency. Do not force food or liquid into the mouth. Use glucagon, a rescue medicine that raises glucose if it is available and someone knows how to give it. Emergency services are still needed because the low can return after the first recovery. Outside an emergency, people using insulin or sulfonylureas should keep glucose tablets nearby and know their warning signs. They should check glucose before driving when symptoms appear or meals have been missed. Repeated readings below 70 need a medication review, not repeated rescue sugar alone. Wegovy and Zepbound can be linked with low blood sugar, but some people face a much higher risk than others. The highest risk person usually has diabetes, another glucose-lowering medicine, and a recent drop in food intake. Measure the glucose, identify the other medicines, and match the timing. Those 3 steps separate discomfort from danger. Medicine simplified. That's what this channel does. If you want more, hit subscribe. This is not medical advice. Consult your doctor.